Welcome to this module. This module will be covering some of the myths of addiction together with stigma around addiction. And I've chosen this first slide to kind of drive home a point. Words have power. Now in that case it looks like a version of, well, not Scrabble, but one always like plays Scrabble and tries to make ridiculous words with some of the harder letters that have really high letter counts. Words truly do have power. The words we use every day are the ways we think about ourselves, the way we think about others, the way we communicate with others, which may be interpreted correctly or incorrectly. And words could hurt. We've all been in fights, perhaps, where something has been said that really drives right into the heart. So words have incredible power. And I want to point out three words that didn't tend to work. In the 80s, there was a campaign which invited people with substance use disorders, back then called addicts and addiction, to just say no. And everything we understand about compulsivity, addiction, substance use disorders, alcohol use disorders, everything we understand tells us now that this is a ridiculous thing to tell people, because the very act of compulsivity means I don't really have full conscious control over it. So tongue-in-cheek, I suppose, this hasn't been working for anyone since the 80s. Maia Slavovitz wrote a book called Unbroken Brain, and in it she has this quote. We had this idea that if we are just cruel enough and mean enough and tough enough to people with addiction, that they will suddenly wake up and stop, and that is just simply not the case. I can't state this with enough emphasis. If all people have is a hammer, all they see with clients is a nail. And no matter how hard you hit it, you're still just hitting it with a hammer. The tough love approach, it's been very romanticized in movies. It's been romanticized and people often get very frustrated and they get forlorn and they get lost and hopeless. And it seems so attractive to finally hit something really hard. But in all the clinical work we've done, and truly from her book as well, if you're tough enough and hard enough, it doesn't mean you're going to get the outcome. The main reason for this with addiction is that we've done this silly thing you see in the past with addiction. We've treated the disorder as the symptom. What I mean by that is we see someone drinking too much and we think that's the problem. Of course, it is part of the problem. The same way a headache is a problem if you have a brain tumor. The headache certainly is very, very upsetting, but perhaps the brain tumor is the place we should be looking to solve the problems. Addiction is very much the same. And for too long, we've treated the behavior of the person when they're inebriated as the problem, or we've treated the places people find themselves when they are doing heroin or meth as the problem. That is not the problem, that is the red flag. If a person is drinking too much or drinking compulsively or using heroin compulsively, the issue is not, of course, the heroin. The issue is, why is that person having to lean into heroin compulsively? Why are they always redirecting their energy into alcohol? In the past, the answer was, because you're an addict. And I'm going to get to that shortly. We don't use that word at Recovery Direct, and it's not a very helpful word. Calling someone an addict is much like calling someone with cancer the cancer. You wouldn't say, oh, we're inviting cancer for dinner. But we'll happily say, oh, my son's an addict, he's coming for dinner. And that for me is very strange about mental health. We haven't quite caught up with the rest of the medical fraternity. So it's very important that we don't treat the disorder just by the symptom. In other words, we don't just look at the headache, we must find out where the tumor is. We don't just look at the drinking and say, stop drinking. It's like telling someone with a brain tumor to stop having headaches and to treat the headaches, treat the headaches, treat the headaches. And eventually we make the headaches go away, but the tumor is growing and growing and growing. Not good enough. It's not good clinical practice. There's a quote here that I really loved, and it starts to speak to some of the myths and some of the stigma around addiction. In all my years as a physician, I've never ever met an addicted individual who wanted to be an addict. If you talk to people who are at their low points because they are so compelled and so overwhelmed by their substance use disorder, you say, oh, well, when you were growing up, was this really how you saw yourself? No, it's not a goal for anyone. So why should we label someone with that really unfortunate word? And the issue, and this comes from Maia's book, Maia, if you're watching, and I apologize for the pronunciation of your name, it's how I assume your name is said. The moral model of addiction has not been completely replaced by other models, and many people, even medical professionals, sometimes find it difficult to separate the person's character, the intrapsychic character of the person, and the negative consequences of their compulsions. What I mean by that is, if I have a compulsion, and if you've watched Addiction 101, you'll see when I throw the switch and I compulsively move towards that safe target, that reliable target, and then I have rage, so I drink a lot, I'm then inebriated. And the things I do when I'm inebriated are probably quite awful. Well, from harmless all the way through to really, really traumatic. And so being around that is very, very hard. It's very hard to be around someone who is so compulsively addicted, who is so embedded in their disorder. It really is hard. But the problem is, we cannot describe the person by that facet alone. And if we do, we run the risk of lazy thinking. We become convinced that a person and the character is the same as the symptom. We become convinced that Ronaldo is only a good soccer player and nothing else. He is nothing else but only a good soccer player. He can't possibly be a good father. He can't possibly be a good swimmer. He's only a good soccer player, because we look at a symptom and we describe the entire character of that human being by that symptom or the consequences of that symptom. It is a faulty logical process to do that, and it doesn't help us in treating people. In 2016, Michael Botticelli wrote a paper for the Obama administration. The words we use matter. Caution needs to be taken, especially when the disorders concerned are heavily stigmatized, as in substance use disorders. When the top people in the land figure out that people aren't getting treatment because they're too ashamed of the labels they're going to get: addict, alcoholic, addictive personality, rock bottom, clean, dirty. People are so afraid of these labels that they don't seek treatment, which is counterintuitive, which means we should be doing something different to encourage people to get treatment. He says, most importantly, if we ever want addiction destigmatized, we need to find a language that's unified and that is not based in moral code. This is not a moral disorder. This is a clinical disorder. There was a man some time ago, some of you may recognize him, Sigmund Freud, and he wrote at the turn of the last century, "We are what we are because we have been what we have been. The person I am today is a very complex tapestry of the inner workings of the experiences I had growing up. And what is needed for solving the problems of human life and motives is not moral estimates, addict, alcoholic, but more knowledge. We have to think carefully about these things, how these etiologies exist, how the causes, how things begin, how someone arrived at this place. They weren't like this when they were born." So there are 3 books that are very important to me as a lecturer here at Recovery Direct. The Heart of Addiction by Lance Dodes, MD, Unbroken Brain by Maia Slavovitz, and Gabor Mate is quite famous in the realm of hungry ghosts. And I think when we consider the stigma of addiction, the stigma of substance use disorders, these 3 people really understand and have encapsulated it perfectly. Lance, in his book, The Heart of Addiction, gives us a framework, a fundamental understanding of how addiction actually works. Maia, in her book, for the first time, combats the disease model. My apologies, she may not have been the first time, but she certainly was one of the loudest speakers on it, that this is not a broken brain. Your brain is not broken. Your brain isn't different to other people. This is a learned disorder over time based on developmental trauma, leading to incompatible relationships or relationships that I cannot lean into, and then redirecting my energy on safe targets. And then finally, Gabor Mate, he gives us an insight into the trauma and how trauma is so implicated into so many mental health issues. Trauma really is the bedrock, or unprocessed trauma more accurately, or trauma that has somehow changed our belief system and adjusted who we are. So in terms of when we think about addiction, so if you yourself struggling with substance use disorder or alcohol use disorder, or you know people that are, you're watching this on behalf of other people, I encourage you strongly, please start using language that encourages restoration and doesn't discourage it with shame. Some of the words we can look at, instead of using the word abuser, drug abuse, and addict, and junkie, those words are not useful. They are lazy thinking, lazy thinking. We need to look at what that really is. This is a person that has a substance use disorder. Yes, they've reached a place in their life that is very sad and very lonely and very upsetting to them and to people around them, but they are still just a person with a substance use disorder. They're not simply a junkie or an addict. That is not helping them, it's not helping the family, and it's not helping the person speaking to them. Use first-person language. Clean and dirty, these are very strange terms. So it implies that if someone's still taking drugs, their blood is dirty. We don't say that about someone with cancer, that your blood is dirty. Someone suffering from leukemia, we don't say, oh, your dirty blood. Can't wait till your blood's clean. We wouldn't use that language. We shouldn't do it with people struggling with mental health issues. And then finally, lapse, relapse, and slip. These are actually Latin terms from the Catholic Church. And they refer to God and turning one's back on God. And they're not suitable when treating someone in a restorative process. So instead of saying lapse, relapse, and slip, I think morally neutral terms are better. Like, my cousin, he has a substance use disorder. He's had symptoms come back again. You can see his drinking's come back. The symptoms are back. That is a much more natural, humanistic way than saying, well, my addict cousin, he's just drinking again. So I think it's important to look at this, and the language is important. Shame is such a blanket over these people that struggle with this disorder that it really isn't fair. Change the language, change the belief. Change the belief, reassert personal power. We need to make sure we use the best possible language when treating something that is so difficult to treat. It is not fair. In no other fraternity is the person that struggles with addiction responsible for their own progress in their disorder. If I walk into a hospital with cancer or diabetes, the people around me rally and they make a plan. If I leave the hospital still untreated diabetic, still untreated cancer, you don't have the people looking at the person leaving going, well, it's your fault. You didn't work hard enough in the hospital. You should have worked harder. But we do this for people struggling with substance use disorders. They're going for treatment, and when they come out and they're not well, it's not the treatment methodology's problem. It's not the practitioner's problem. It's the individual. We don't do this in literally any other medical fraternity. For some reason, with addiction, it's okay to blame the client. It's okay to blame the patient. It's not okay. It's not okay, and it's not good science. It's not good practice. It's not good, not a good belief system to carry, and it loads everyone with stigma. So let's look at some of the myths, the commonly held addiction myths. And there's been a lot of press recently, and a lot of people have been doing a lot of good work to try and offset a lot of these myths, but it bears some repeating for some of them. So I'd like to go through a few. The first one is a very popular myth. And in some ways, it's almost like it's a myth created to make us feel better about addiction in some ways, because it makes us feel like people aren't really responsible, or there's no human element. It's all about the drug. The drug lured them in. It's just so addictive. It's got such crazy addictive properties. You just can't help yourself. So I want to say two things about this. The first is that there is psychological addiction and there's physical addiction. What we treat at RD is psychological addiction. Anyone can have physical addiction. Physical addiction's other name is withdrawal. Anyone taking anything long enough will form a habituated, in some ways, level of stasis on it. And when that level drops, the body will crave biologically more of whatever that is. It could be sugar, it could be opiates, it could be whatever. The trick is to manage it when the amount doesn't come in anymore and let the body have stasis again. Let the body balance itself out. And for different substances, these durations are different. I stand to be corrected, but nicotine, I think, is 3 or 4 days. And the body finds stasis, biologically, physical stasis. With alcohol, I'm sure it's no longer than 2 or 3 days, maybe even less than that. With opiates, it's probably a week. So you see the durations for these things is quite small. So physical addiction affects absolutely everyone and everything. It's when I pour something in, the body gets used to it, I stop having it, the body rebels. But after enough time, there is stasis in the body and all is well physiologically. But psychological addiction, on the other hand, that's when a month or 2 months have passed and I flick the switch and I head towards that object, whatever it is. And that's very different to a physical effect of the drug. So you'll see this a lot, that the drug in and of itself, it says on the packet, tobacco is addictive. Well, I suppose it has a very, very strong withdrawal factor, but that doesn't sound quite as sexy when you write it on a pack. Warning, cigarettes have a very strong withdrawal factor, So it's going to be hard for you to not have another one. Instead, they've put the word addictive on there, which is quite crazy because it's not in and of itself addictive. It has a strong withdrawal factor and also it might be very psychologically compulsive. The second thing I want to get into is genetics. This is very popular, and I think it's what used to be called alcoholism, which we refer to as alcohol use disorder. This made this genetic factor really popular. No one is still yet to find a sequence of genetic code that really explains a genetic factor. And so I'd like to offer a different view. I would say that it looks like genetics, but it's often hereditary. Let me explain. My dad's a drinker, my grandfather's a drinker, and I'm a drinker. You see, all the men in the family is all drinkers, right? So if I look at that family and I start asking pointed questions, I'll probably see that grandfather had a lot of developmental trauma with his great-grandfather. And living under that developmental trauma means he became maladapted to the world and eventually formed his own relationship with inanimate objects like alcohol, whatever it might be. And then, unfortunately, his son grew up with him and then also experienced that developmental trauma. But it's not biology, it's social. It's a social hereditary disorder. It comes from the generation above. Their unprocessed trauma moves down because that trauma affects the way they behave with their next of kin. And so on and so on and so on. And so it looks like genetics because I trace the line up, but let's ask questions about, well, what were the childhoods like of your parents and your parents' parents and them before? What was their developmental trauma like? Did they have any? What was it like growing up? What kind of trauma were they around? And then more importantly, what were they like with you? So we see this very often. The other point is, and Lance Doty's in his books points to this, is that it's very reductionistic to talk about genetics as having this massive role in something as complex as human behavior. Height, sure. Eye color, fantastic. Type of hair, absolutely. But behavior is a very, very complex set of systems. And one cannot explain it by a simple gene which creates a protein. This I've covered a bit in the previous slides. Often we see that you're born an addict, an addictive personality, a destructive human being. None of that is true. We know that there is social learning which tells us over time, we internalize about the person that we are, what we can and can't do, what we are allowed to say to other people, what we're not allowed to say, how we can share, how vulnerable we can be. But no one is born with a substance use disorder. It doesn't exist. So when someone says that it's a moral affliction, that doesn't belong in science. It doesn't belong in clinical oversight. It also prevents us from treating the disorder properly. It's the same thing as, and I think praying for cancer, if that's what one does, is wonderful. But praying for cancer is one side. Then there's clinical process, which is whatever might happen on a biological level with intervention with pharmaceuticals or surgery. Both are fine, but leaning on one only, not a good idea. With addiction, unfortunately, because of those behaviors that people have whilst they're under the influence, it looks like they're just crazy human beings. So it's much easier to then just load this moral kind of association on it. But we need the same approach as we would have with cancer. Thorough, clinical, restorative, and measured. This brings me to a point about thinking about the disorder differently. We need to think about addiction as a clinical disorder and not as a moral affliction because it helps us treat the client. And that's so important to getting people into treatment. And then finally, Maya Slavovitz talks about this, the broken brain. There are no broken brains. If you look at twins and the one becomes a bodybuilder at the age of 15, 16 and the other one doesn't, becomes an academic. If I go fast forward 20 years and I take a snapshot, a photograph of both of them, they're going to look quite different. Same, but quite different. The same with the brain. If I take someone who's been, drinking for 20 years and someone who hasn't, and I scan their brains will look different. The brain is incredibly plastic. It can change all the time. It has an incredible ability to rewire itself under stressful situations. So the brain scan does not work. These are just some of the many kinds of myths around addiction. But I want to leave you with one thing today, and it's that if we continue to perpetuate the myth, we stop thinking about solutions. We get to these cul-de-sac ways of thinking. We stop actually applying ourselves with how does this actually work? What is going on with this client? What is going on with you? What's happening in your world? What's happening in your relationships? We just go, stop drinking, stop drinking, stop drinking. Don't be a crazy person, stop drinking. That's not good enough, and it's not working. As Nancy Reagan tried to say in the 80s, just say no. But it never actually worked. When that campaign came out, there was a rampant increase in drug use.